Hello, everyone. Welcome to our July ICARE case conference. I'm Tua Pal, and I'm just going to go through some housekeeping first, and then we're very excited to welcome our guest expert. So the schedule for next year, I just wanted to kind of outline here are the dates that we have settled on. We are going to have a slight change in the time. We're moving it up by 30 minutes. So it'll be 11 to 12 Central Time, 12 to 1 Eastern Time. It remains the second Thursday of the month unless there's a conflict with another national meeting. So for the most part, it's every second Thursday of the month. Also wanted to thank everyone for their referrals to ICARE. We try to make it as easy as possible, either through the referring your patients through the online referral form. We're happy to send prepaid postcards. Additionally, we really appreciate it when folks submit cases for presentation, either aligned or not aligned with the theme of the case conference. Again, we're happy to put cases together because we have enough cases that are complex, but this is a great forum to get additional insight into cases. So again, we appreciate your engagement. Just a reminder of resources that are available through ICARE. We have our monthly virtual case conferences like we're having today. Our website is searchable. Also, any resources we put out, we also make searchable on our website. We do our biannual newsletters in the fall and the spring, and then we are active on social media, as many of you know. And these are just some examples of our social media posts from the last month, including talks that we publicize, newsletters, open studies, stories, research updates, as well as guideline updates. In terms of ICARE focused efforts, we're still actively recruiting for our genomic characterization of breast cancer study, really focused on BRCA1 and 2, PALB2, ATM, and CHEK2. This is in conjunction with my colleague at Vanderbilt, Sonia Reed, as well as some other colleagues at Stanford, Alison Kurian, as well as Mayo, which includes Fergus Couchin, Sid Yadav. And really what we're doing is testing on tumor samples through Tempus, both DNA and RNA based analyses. We have subsequently combined our data set with the Tempus data set, and we are comparing to existing sporadic tumors. Just wanted to show, again, we are very grateful to all of you for continuing to refer your patients with hereditary breast cancer gene mutations. Just wanted to present really quickly some results that we have. These were presented at the ASHG 2024 meeting. These are an outline of our current numbers. And you can see that we have a distribution of early and late stage cases, which is unique about this cohort, looking at distribution of receptor status across breast cancers. And again, you can see BRCA1 definitely enriched for the triple negative subtype, which is not a surprise. We've also been able to look at it by intrinsic subtype. And again, what we're seeing here is with the triple negative cases, again, we'd expect the enrichment of basal, but even for BRCA1, the HR positive cases, pretty enriched for basal subtype as well, which we're absolutely not seeing in ATM and CHEK2. And then again, this is data that's been submitted for publication, but unpublished at this point. But trying to show a preview with our somatic mutation profile, we have seen some differences both across HR positive, HER2 negative cases, as well as our triple negative cases with significant results across the 5 genes, but more to come on that. We also, over the last month, had release of our genetics familial colorectal, endometrial, and gastric cancer NCCN guidelines. So again, those were released on June 13th. So I wanted to provide some highlights. This is by no means comprehensive, but I just pulled out some of the updates. And what I've done is I've put the page numbers per the NCCN guidelines, but also on the PDF, it's page 50, because I find that sometimes these guidelines are kind of hard to navigate. Now, with MSH2 and EpCAM, there was a row on sarcomas added based on recent publications. And again, there are some risk estimates. At this point, there's no clear evidence to support surveillance. So again, that is outlined in the guidelines at this point, but this was a new change. PMS2 was greatly abbreviated in terms of cancer risks. So there were multiple cancers that were removed. And basically, it was replaced with, well, Lynch syndrome associated cancers have been observed in individuals with PMS2 Lynch syndrome. It is unclear whether PMS2 Lynch syndrome carriers have increased risk for these cancers. So again, I would check that out. That was, a fairly substantial change there. Looking at surgical options and individualizing care for Lynch carriers, what was stated, this is on page 65, account for genotype, phenotype, family history, and personal considerations. For example, extended colectomy may be more favorably considered for individuals with higher risk genotypes, so the MLH1, MSH2 carriers, or a stronger family history of colorectal cancer, Lynch syndrome associated. And then segmental resection, again, lower risk genotypes was kind of the general guidance that was given. Moving on, Poitz-Jaeger syndrome, there were some diagnostic criteria that were updated, so I would check those out as well. For CDH1, for stomach cancer, now limited to diffuse in the table. Signet ring was removed, and the reason for that, as all of you or many of you know, is that that feature, the signet ring feature, is pretty much present in all patients. And again, some updated risk estimates were provided for both stomach cancer as well as lobular cancer. And then again, the importance of sending to an expert center was also highlighted in these guidelines. With NTHL1, what they indicated for duodenal cancer, baseline upper endoscopy, and then what I found interesting, I wasn't familiar with this data, heterozygote cancer risks are unclear, but have been observed. So again, there's not any definitive data at this point, so nothing changes, but this is, again, something to keep our eyes on. And then TP53, colon cancer risks were updated. They were actually changed from greater than 20% to 5 to 20%. So that is a change. And then the age used to be 25 years, but it was changed to 20 to 25 to give more wiggle room. And then, as many of you may have realized, the genetic familial breast, ovarian, pancreatic, prostate guidelines were just released today. So I wanted to provide some quick updates on this. And this is going to be aligned with our guest experts' expertise, but with testing for ovarian cancer susceptibility, CRIT4, there was a third bullet added, personal history at any age of non-epithelial ovarian cancer, the sex cord tumors with annual tubules, small cell carcinoma of the ovary, or I think some people call it SHOT, at any age. And then a footnote Z that acknowledges that testing for DICER1 and SMARCA4 is appropriate. Management guidelines are evolving. Consultation with expert gynecologic oncologist is recommended. Again, these are kind of rare syndromes. They're not yet in the tables, the gene tables, but there was some guidance about this because they are nowhere else in the NCCN guidelines that I'm aware of other than this specific guideline. And then again, this is again a fairly substantial change. Testing considered with a personal history of serous tubal intraepithelial carcinoma, or STIC, as many of us refer to it, at any age. And again, evolving evidence suggests STIC could be associated with higher rates of BRCA1 and BRCA2 likely pathogenic variants. And then testing for pancreatic cancer susceptibility, we called out including Asner cell carcinoma, which definitely seems to be something that is associated in potentially higher risk. And then we've also called out atypical risk variants in BRCA1, BRCA2, ATM, CHEK2, et cetera. And the revised language, and this is across all of these genes, is risk-appropriate management should be considered. Management should be based on best estimates of cancer risk for the specific pathogenic variant in conjunction with personal and family history. So again, recognizing that, all BRCA1 mutations are not equal. There are ones that are lower risk. Same goes for CHEK2, which we've had in the guidelines for a while. And then we do know of a higher risk ATM mutation as well. And then for CHEK2, main thing here is we added the THR 476 MET variant to these guidelines as a lower risk variant. With PALB2 TP53, we've now added the prostate cancer risk and then screening starting at age 40. And then for Cowden syndrome, thyroid ultrasounds starting at age 12 used to be age 7. Then BRCA management, again, I won't go through these in detail, but there were some, I think really the way I see it is clarifications regarding clinical breast exam that should continue after risk-reducing mastectomy. Again, I think that's pretty much probably happening anyways, but now it's in the guidelines, looking at just, again, clarifying the risk for primary peritoneal cancer that remains after risk-reducing salpingo-oophorectomy, and then some text specifically calling out the salpingectomy and the importance of completion oophorectomy down the road. The hormone replacement options, again, I think were clarified. There was some language that we clarified to make it more clear. Now, two other things I wanted to mention. There was a panel, because there have been a lot of changes to both the KEG and the BOP guidelines over the past year. So there was a session that I moderated at the annual NCCN guidelines meeting, and there is a paper, kind of a highlights paper that was published. And again, you can see this, we had some great speakers that commented on the prostate cancer updates, endometrial cancer updates, gastric cancer, as well as the genetic counseling perspectives. The link is available that we can send out. And the session, I was surprised, is also available for listening to in case anyone is interested. And it's free. It's, I think, available up until March, if anyone wants to check it out. I wanted to start off with a case aligned with our guest expert speaker's presentation today. So this is not my case. It was a case that Dr. Ronnie Alvarez sent to me that he had. And this is a patient currently 66 years old. In 2017, she had advanced stage recurrent or advanced stage ovarian cancer age 58, which has recently recurred. She was treated with THBSO, hemicolectomy. She had a mixture of Taxol, carboplatin, then docetaxel and carboplatin. Genetic testing identified a RAD51C mutation, and here is the specific mutation. 2018, she had a recurrence, completed, again, another cycle, doxil carbo. 2018 to 2022 was put on olaparib maintenance when she was then diagnosed with MDS, treated with decitabine and venetoclax venetoclax until late 2023. Additional MDS treatment started in January 2025. And again, what you can see is she's actually doing pretty well. She's got some other risk factors like long-term smoker, has COPD. She's, again, excited about many things in her life. You can see the family history where mom had breast cancer age 75, and then maternal grandmother with melanoma, maternal great aunt with stomach cancer. So with that, I wanted to introduce our guest speaker today, Dr. Elizabeth Swisher, who's the Deputy Director at the Fred Hutchinson Cancer Center, University of Washington. She's professor in the Division of Gynecologic Oncology at the University of Washington. And again, she probably doesn't need much of an introduction, but she's had longstanding interest in genetics, personalized therapy for gynecologic cancers. And her focus today will be myelodysplastic syndrome and acute myeloid leukemia following PARP inhibitor therapy. So Dr. Swisher, just wanted to get your perspectives on the case that we just presented, or that I just presented, and then we'd love to learn more from you today.
Yeah, thank you, Tia. I'm really happy to be here today. And thank you for finding a case I'm going to start off my presentation with a case, and I think you'll see some parallels there. So one of the reasons ovarian cancer patients have such a high risk of therapy-related myeloid cancers is that we treat all of our patients with platinum-based chemotherapy, which is one of the more leukemogenic chemotherapies. So there's a baseline risk, and then PARP inhibitors add to that risk. And so the person who has the highest risk are people who have had more than one regimen. So this patient that you presented had 2 different regimens that were platinum based, and then an extended period of PARP inhibitor maintenance. So the maintenance trials, now we've moved PARP inhibitors to the upfront setting, I think, where we see a lower risk of AML and MDS, but these patients who are treated in the recurrent setting, by definition, have had at least 2 different full treatments with platinum. And then those trials, there wasn't a limit to when the PARP inhibitor was ended. So you treated until progression. So we have patients treated in this era of this patient who got, as this patient did, 4 years of PARP inhibitor. And in the upfront setting, patients are getting 2 years and just 1 regimen of platinum. And now there's a clinical trial ongoing at the NCI through NRG Oncology group, where we're comparing 1 versus 2 years, because even that 2 years, it was just arbitrary. As some of you may know, in breast cancer, the maintenance approval for olaparib with patients with germline BRCA mutations for breast cancer is 1 year. That also was arbitrary, so nobody's really compared that. So understanding that risk benefit ratio, we've massively improved outcomes for patients with ovarian cancer, but AML, MDS is like a potentially fatal diagnosis. And many of these patients, the PARP inhibitor related ones, are usually P53 mutated. So I don't know, Tia, if you have any information, but those are the higher risk MDS for transition over time to AML, which ends up being kind of the fatal thing. So I don't know if you know her profile.
I don't, because she was Ronnie's patient, but that is good to know. Okay, Liz, take it away. Take away your presentation.
Okay. That was a good introduction. And so I am going to talk about MDS and AML following PARP inhibitor therapy, which kind of collectively, really, there's sort of a continuum from MDS to AML, and even things that are sort of in between. So collectively, we call them therapy-related myeloid neoplasias, or TMN. So I may refer to it as TMN, which is shorter. And so I was just going to present this case. This is actually a sporadic case, so I don't have a pedigree. This is a 56-year-old patient who was diagnosed in 2007, who her family history was really only notable for a father with prostate cancer. She underwent a THBSO, and it was an incidental finding of stage 2C high-grade serous ovarian cancer. She got 6 cycles of carbotaxol, which is kind of our standard regimen, and didn't recur for quite a long time. In 2018, recurred in the liver. She had a surgical resection again and got 6 more cycles of carboplatin and Taxol, and then underwent genetic testing, which was negative for germline mutation, but Foundation 1 testing of the tumor revealed a somatic mutation in BRCA2 that was pathogenic. And so she went on olaparib maintenance for 4 years, which is kind of almost the identical story to the one that was just presented, except that her mutation is somatic and not germline, which has equal predictive value for PARP inhibitors. And so again, because it was the recurrent setting, she was kind of left on it indefinitely. But this was at our institution where I was sort of like talking about AML and DS risk, and her provider, reached out and said, should she still be on it? This patient had a 11-year remission without PARP inhibitor. Now she's in remission again. And what's the risk benefit ratio of continuing indefinitely versus seeing how she does? And so after 4 years of treatment, they did stop in March of 2024, that PARP inhibitor. And she remained in remission, and they decided to stop it secondary to the risk of AML MDS, which accumulates. And but unfortunately, 8 months later, she was diagnosed with a therapy-related AML. She was treated, initially responded a little bit, but ultimately declined and died in June of just this year. So her AML did have a pathogenic P53 mutation, which is sort of which is classic for the therapy-related AML or TMNs. And the VAF in her blood was 42%, which was, consistent with a high blast fraction in her blood. So that I'm going to kind of set the stage there. That's similar presentation, and I'm going to kind of come back to kind of what we know about risk and how to monitor that potentially, or should we monitor that? And we have a prospective study that potentially you may run across patients who we'd be very interested in enrolling. So, sorry, there's a delay. So this was a paper published off SEER Medicare data, just looking at the risk of TMN across solid tumor patients, a very large number of patients. In the ovarian, fallopian tube, peritoneal cancer group had the highest increased risk compared to other solid tumors, along with a few others, small cell lung, sarcoma, and brain. And the risk is known to be higher with certain types of chemo, platinum being one of them, alkylating agents, and radiation also increases risk as well. But PARP inhibitors further increase that risk. So this is a meta-analysis of many PARP inhibitor trials. A lot of those trials were ovarian, so like 43% of the trials here were ovarian cancer patients, but that included the larger trials and the longer follow-up, so that the ovarian cancer patients contributed a lot to the TMN risk in this group. And they calculated an odds ratio of 2.6. With an incidence across the trials that was only 0.8%, but many of these trials were shorter trials, et cetera. So I think that that's actually a minimum incidence risk, and I'll talk a little bit about things that increase that risk. So these two patients represent the highest risk group for subsequent TMN, which is having had more than one regimen of platinum and then being on a PARP inhibitor for 24 months or greater. And in 2 trials in ovarian cancer, that risk is about 10%, which is a very high risk for somebody who has a relatively good outcome in terms of their total expected life expectancy and in risk of recurrence from their secondary cancer. So in one of these trials, it was 11.4% and another 8%. But notably in the SOLO2 trial, which the PARP inhibitor treated patients that also met that the patients who got placebo instead of PARP inhibitor that met the same criteria had a risk of 4%. So just that baseline platinum exposure is increasing your risk quite a bit. It's definitely not all the PARP inhibitor. So how can we potentially predict who's at risk? So we know that somatic mutations are acquired by all cells throughout life. And CHIP, or clonal hematopoiesis of indeterminate potential, I'm just going to call it clonal hematopoiesis throughout this, or CH throughout this talk, it's a non-malignant expansion of myeloid cells where a mutation a rare mutation has occurred in hematopoietic stem cell, and it's led to clonal expansion. This is actually kind of a normal process that occurs with aging, but if additional mutations are acquired, blood cancers may result. And it is known that, sorry, I'm going to go back. It is known that P53 mutated clonal hematopoiesis is a risk factor for subsequent AML in the non-cancer population. And you can find a clone in the blood, usually number of years, like at least 5 years before the diagnosis of AML. So that sort of led us to the conclusion we were finding some of these clonal hematopoiesis in our patients on trial, and we were wondering if these are the patients that ultimately are at higher risk of, of subsequent TMN. So what we did was we took 2 existing large trials that used rucaparib from Clovis Oncology, which is now a defunct group, but they ran a couple trials in the recurrent setting. Ariel 2 was a single arm study, so no placebo control, but looking at rucaparib as a monotherapy treatment. And Ariel 3 was in the maintenance phase, post a second or third line platinum response. So TMN across these 2 trials occurred in 2.1% of patients, and that's within a couple of years of the trial. So ultimately, that number only goes up with longer term follow-up. And what we found, if we looked at the patients who got TMN and the patients who didn't get TMN across the 2 trials, and then did multivariable analysis for the significant factors, what came across is it's the total prior time to receiving platinum. So that's the number of months of platinum exposure is a major risk factor. And then also the total time of PARP inhibitor exposure. It is a risk factor. So one of the things is people have wondered if having a BRCA mutation itself increases the likelihood of acquiring TMN. Is there less capacity maybe to repair DNA damage in the hematopoietic stem cells themselves? And what we found in this study was, in univariate analysis, BRCA mutations were a risk factor, but somatic equally to germline. So why would that be? Because the somatic ovarian cancer mutation shouldn't be in the blood cells. But it turns out when we corrected for the amount of platinum exposure, that risk factor went away. So patients with BRCA mutations, their cancers are more sensitive to platinum. They tend to get retreated with platinum again. And that may be the fact that is leading to their TMN as opposed to the underlying genetic, predisposition. This is a retrospective study looking at who got TMN and didn't. And so we definitely want to kind of further look at that in a prospective fashion as well. So what we did was in these 2 trials, we took the cases that got TMN. So even though it's a large number, we just have 20 cases. And we took like double the number of cases, matched them for age and other risk factors who did not get TMN, and looked at and then did deep sequencing of their baseline blood samples and compared the clonal hematopoiesis in the cases versus the controls, meaning the patients who didn't get TMN. And looked at like what genes were involved, and it was definitely P53 clonal hematopoiesis that raised the risk factor for MDS and AML. This was using a cutoff of 1% of a variant allele fraction for the clonal hematopoiesis. So it was the TP53 mutated clonal hematopoiesis was associated with prior platinum. exposure, like the amount. DNMT3A, which is associated with age, that's a common, and it did not associate with the risk of TMN. So then we had some serial samples. We used cell-free DNA here as opposed to just the blood, but most of cell-free DNA is coming from the blood, even though we're using it often to look at circulating tumor DNA. The circulating tumor DNA fraction is low, so you can use cell-free DNA also to look at the blood component of your clonal expansion. These are all patients that got TMN, and when we had samples over time, their P53 mutations in the blood were expanding. The clone was expanding over time, and these are just, 4 different examples. So we don't have patients that didn't get TMN that we had serial samples on that had a P53. So we don't know what the clonal, we just don't know what those clonal dynamics are normally during treatment versus in a patient who's gonna ultimately be diagnosed with TMN. So that led to us wanting to do a prospective study to try to answer that question. So we kind of came up with this model, which is that a patient with ovarian cancer maybe has an age-related P53 mutated clone in their blood, and they're maybe in remission, and there's stability of this clone, and then they recur, they get more platinum, which expands this clone, and then they get PARP inhibitor, which further leads to transformation of the clone to a TMN. So that was kind of like the model that we were sort of wondering if that's the case, could we come up with like a risk calculator for people to know what their absolute risk of TMN is, and potentially lead to interventions in the future. So we want to know what's the absolute risk of TMN. If somebody has a P53 clone, is that a relative contraindication, or is that somebody that should be monitored? If so, how would you monitor them? Without knowing what the clonal dynamics are in the baseline, we can't really advise about any of that. So that led to this study that's an R01 funded study. We call this study CHANCES, which stands for Clonal Hematopoiesis in Cancer Survivors. And our goal is to better understand that relationship between cancer treatment and the development of secondary blood cancers, or TMNs, and to develop a risk calculator for individuals so that we can identify who's at higher risk and ultimately prevent the development of TMN in cancer survivors. So our study eligibility is patients who have had, ovarian, peritoneal, or fallopian tube cancer, who plan to complete, so we could enroll them at baseline at least 5 cycles of platinum-based chemotherapy. They can be in remission. They can be in remission. They can be in recurrence. They can be at any point in their ovarian cancer journey, except we want at least 6 months of expected life expectancy because we're trying to follow people over time. And then we are also wanting to recruit patients with other solid tumors who have PARP inhibitor exposure. So we didn't want so much heterogeneity of just taking all cancer patients, but we do want more diversity of cancers that are being treated with PARP inhibitors. So anybody who's going on a PARP inhibitor or has been on a PARP inhibitor for 4 months or more, we would love to enroll that individual. And across the spectrum of age is useful for us. So we have enrolled. So this is kind of how it goes. If somebody wants to enroll, they enroll entirely online. They fill out a REDCap form with their treatment history. They provide us a blood sample with a kit that we ship to them. And we get a blood sample every 6 months for 3 years. And each 6 months, they give us an update, a short survey on their treatment exposures so that we can sort of look at how the clones are behaving in people who are not on treatment versus on treatments and treatments of different types. We freeze the blood viably, and then we sequence on a custom panel that we call BROCA-MY for myeloid that can identify clonal hematopoiesis with confidence to less than 1%. We only consider clonal hematopoiesis for pathogenic or favor pathogenic variants in the genes on our panel. So I'm just going to wrap up with a last case. So this is an unfortunate case that I took care of this patient. She happened to have a history of Hodgkin's lymphoma in 1993, where she was treated with high-dose chemotherapy, chest radiation, and stem cell transplant. So quite a lot of exposure prior. And so this is really relevant to our patients who have more than one cancer. what is their prior exposure before they're even getting treated for their current cancer. And in 2016, she was diagnosed with ovarian cancer. She had no germline mutations. And she then was, you can see up here at the top is kind of her treatment regimen. She had 3 different regimens with platinum, and she never did get a PARP inhibitor, but she got diagnosed with MDS, which shortly prior to her death had converted to AML, and it was a P53 related clone, and it is this K132R pathogenic variant. And you can see we actually at the time of her diagnosis, she enrolled in our biorepository. So we did have a baseline sample before she enrolled in Chances here, where we got the serial samples. So we went back and looked, and she did have a low frequency, like 1% frequency of the clone that ultimately became her MDS 6 years later. And it fell here before her clone because she initially responded to MDS treatment, and the size of the clone will of the, you know, like you would imagine, if she's responding to treatment, that size of the clone will fall. But we didn't get a sample at the time of her death, but it spiked way up at the time of her death. But interestingly, she has this, you know, pretty high level frequency DNMT3A clone up at the top, where she had a 13% clone at baseline. Now, DNMT3A is like probably one of the most common clonal hematopoietic genes. It's associated with aging. And, you know, it went up a little bit and didn't really go up, you know, the same way that the P53 did. I mean, is this a risk factor, you know, somebody who has a large clone at baseline, even in a different gene, or is this just like an incidental kind of finding? I mean, these are the questions that we kind of hope to answer. So I'm just going to say that this study, you know, people can enroll online. We have flyers with QR codes that if you wanted to use them. We also have business cards that we'd be more than happy to send you. This is an enlarged version of the business card, what's on the front and the back. And so it's just a business card size, and it has people can use the QR code or go to the website to enroll. They can also reach out to our email at the, you know, and we would really love to enrich for patients who sometimes, I mean, you guys are doing genetic testing and you may get back a result where there is clonal hematopoiesis in a sample. A lot of the germline testing companies filter out the clonal hematopoiesis, like sort of arbitrarily. Sometimes, though, you're questioning whether somebody has constitutional mosaicism or clonal hematopoiesis. Anybody with clonal hematopoiesis in cancer, we would love to enroll them because we'd love to follow what happens to that clone over time, whether or not they're on or off treatment. Then, you know, patients on PARP inhibitors, patients who come to you, maybe they're disappointed that they have negative testing. They have ovarian cancer, and patients want to answer for why they have cancer, and you're having to give them their negative test results and they seem disappointed. And you can say, but you could enroll in this other study if you know, because sometimes patients want like something positive to enroll in. So I would be really grateful for any referrals. And because I think this is like, you know, a critical thing that hasn't been studied too much, I think, because of the separation of the solid tumor and the liquid tumor world, essentially. So I just do want to acknowledge a lot of, like, you know, all these studies, the big clinical trials involve a lot of people, but my long-term mentor is Mary Claire King, and I wouldn't really be in this genetics world without having had the opportunity, the good fortune to like learn from her and work with her. That's it. I'm very happy to take any questions.
Thank you. That was fantastic. So really what you're saying is they don't even necessarily need to be positive. But let me ask you a question. The patient that I presented at the very beginning, she wouldn't be someone you want because she's already got the MDS, right?
Well, so anybody with MDS, honestly, if somebody has like a poor prognosis, they have therapy-related AML and they're like, you know, hanging on to life, like that's probably too late for us. But MDS is interesting because, you know, it evolves over time. So, and there's not that much known about there's really like small series of MDS that's related to PARP inhibitor exposure. And so understanding the difference between that evolution, is also of interest to us. We're freezing cells viably, so we're able to like go back and look at, we can do single cell copy number alterations, which probably is a big part of progression in MDS as opposed to like accumulation of more small mutations. So yeah, so we're actually are interested in people. The other people that we're super interested in are the people that have cytopenias of undetermined significance, which I know you guys sometimes see. People who are sort of they're not diagnosed with MDS or AML, but they have low counts and people are kind of following them. They may be sort of brewing. And so we like to follow the clonal hematopoiesis in them as well.
Okay, so really anyone, because we have a CHIP clinic here. So anyone
Yeah,
we send to CHIP clinic would
with
essentially
cancer.
be
Yeah,
eligible
yeah.
for your trial.
Anybody 100% with CHIP and cancer. It's just the CHIP patients without cancer that we're not following them.
Okay, but if they don't have CHIP, but they're exposed to PARP, you don't want them, right? Because
No,
you
we want them too. Anybody with PARP exposure.
anyone with PARP. What about platinum?
Anybody with platinum and ovarian cancer, but not platinum and any cancer, because then it's just like too many different things. So basically, it's anybody with PARP inhibitor, anybody with CHIP, and any ovarian cancer patient.
Okay, now that's broad. So,
Yes, it's broad.
and so I would think that many people across, and so they don't even have to have a germline mutation, is what you're saying.
No, they don't have to have a germline mutation. We want patients with and without germline mutations so that we can have the power to compare that. Because ultimately, I think it's probably not their germline mutation that's putting them at risk. It's the fact that they're surviving, they're getting PARP inhibitor, they're getting a lot of platinum, and they're surviving long enough to get TMN, which, if you die from your cancer, you haven't had the opportunity to develop that. So, but we would like to answer that better. So yeah, we want to enroll patients with and without mutations and all kinds of mutations.
And I guess the reason, like for breast, that there might be an association that's being seen is because breast cancer patients are more likely to have a BRCA mutation to then get PARP, right?
Exactly. And
So
also
that,
to get, and historically to get platinum, even
yeah.
though now triple platinum now is kind of being more broadly used in triple negative breast cancer. But if for a while it was being targeted towards patients that had BRCA mutations, preferentially. So I think the exposures are different. And so I think the breast cancer literature hasn't fully accounted for that, which may be that association. But again, just think we need more data to be sure about that.
Okay.
I think Meredith Gerhard has a question.
Oh, yes, thank you. I was just wondering, how do you differentiate cases and do you want these type of cases in your study where like we get a germline result, like I just saw a patient this week, TP53 mutation, possibly mosaic, we don't know, is this chip, is this constitutional mosaicism, is this a true germline variant? Like we do a skin punch, maybe that gives us some information, but if it's not in the skin, then, you still don't know, is this like a chip process versus something like a constitutional mosaicism?
Yeah, so that's a great question. We would love those patients in the study as long as they have cancer. If you're doing it and it's just like not a cancer patient, then that's like a different and very interesting question to sort out, but not what this study is about in terms of the serial sampling. Um, we can, we are interested in constitutional mosaicism too, as a separate study. So we can, if you have patients where you're sorting that out, we've been, sequencing multiple like tissues. Like if the patient ends up, say, uh, we have a series of patients with BRCA1 and BRCA2 constitutional mosaicism. It's extremely small series, like 4 patients. If you have any patients like that, we would love to enroll them in our genetics study, not the chances study. So I'm putting in a plug for something else, but I mean, you can always reach out to me about that because it's very interesting to try to sort out what level of risk patients with constitutional mosaicism have and how we should be counseling them. That's a different issue. But of course, we need to rule out clonal hematopoiesis. And one of our example patients had a BRCA2 pretty large clone in her blood, like 20%, and it actually turned out to be clonal hematopoiesis. And that was pretty interesting because that's not a gene we see targeted with clonal hematopoiesis. And I have sequenced thousands of samples for BRCA2, and just not typically, a gene that's a target of clonal hematopoiesis, but I think you can see lots of different things. So the gene itself can't be what helps you figure out whether it's constitutional mosaicism or clonal hematopoiesis. So,
Okay, thank you so much.
I mean, you can just email me about any cases that you're sort of not sure about might be of interest, because we'd love to just continue that dialogue. A question in the chat is only females or males with aplastic anemia. We're enrolling males if they have had PARP inhibitor exposure. So we have a couple prostate cancer patients that have been treated with PARP inhibitors. So yeah, ovarian cancer or any other cancer with PARP inhibitor, or anybody with cancer and known clonal hematopoiesis or cytopenias or MDS. Aplastic anemia, I think, is a little bit different than a myeloid neoplasia. So if the person had if the person had some other cancer as an inciting factor, I guess, yes, I would want him. But if that's his only hematologic diagnosis, then no.
And do you go back to patients with any results? Because you're getting the serial samples every 6 months. If you're seeing any signals, are those shared?
We do not give specific patient results back because we don't really know how to interpret that yet in terms of, expanding clone, is that a risk factor or not? But what we're doing is we are trying to engage, we just basically are putting together our first newsletter to go out to our enrollees, because now that we have some data to share. We've actually enrolled better on advocacy networks than we have from doctor referrals. Patients are interested in enrolling if we just get the word out to them. And patients are looking to participate, especially if they're in the survivorship time. They're looking to participate in things that they feel like will contribute. I think in this day and age where science is being attacked, one of the ways to combat that or to feel strong about that is to participate in science. So some of our patients, we can encourage them to participate in research as a way to strengthen what we're doing.
Yeah, no, but I think it's great that you're giving them back something, even if it's
yeah,
it's not an individual result, but it's results of the overall findings, which can then be a call to action if needed for anything where you're.
Yeah. So if we find something unexpected, we can reach out if we find something unexpected and clinically significant. So say somebody maybe had their testing, genetic testing, it wasn't panel testing or something else. And it's just that we do that. Most of our patients are ovarian cancer patients, and they've mostly had comprehensive testing. So we don't, but if somebody, say, had a prostate cancer, well, I don't know, they'd be on a PARP inhibitor if they didn't have something already found. But anyway, there is a scenario where we used to more frequently, when not everybody was getting testing, come across a RAD51C germline mutation or something else that we did want to report back. And then we have a process for doing that, reaching out and finding out if the patient wants to receive other results. Most patients participating in research do. And I think at the end of the study, if we've learned anything, we can modify our IRB to reach out and give results if there was something. I just don't think we're going to be doing that in a timely enough fashion to be able to really impact patients. So we advertise the study as you don't get any results. And because we just need to learn more in order to know how to give results back. We don't know if we should be monitoring and who we should be monitoring.
Right. No, totally makes sense. Okay, any other questions? Because I'll start. I think we can at least do one case. So I will. Thank you very much, Liz. That was fantastic. Okay, so here's a case that I saw in the last month or two. It's an interesting case. So the dad, so here's the pedigree, but the original proband, who I've actually also seen subsequently, was tested through 23andMe and had this BRCA2 mutation identified. This was, more than 10 to 15 years ago, and he shared it with his daughter. He's a proactive, like really proactive guy, but I'll go on. She subsequently tested through 23andMe, and this was a while ago, found to have a BRCA2 mutation, and that was filed away. So she mentioned this to a doctor. She was living somewhere else. She moved to the area. She mentioned it to a doc at Vanderbilt last year, who looked into it, and then ended up seeing a gynecologic oncologist at Vanderbilt who did confirmatory testing. So in terms of her care, she gets mammograms and breast ultrasounds. Okay, so she's got a pacemaker, and our breast MRI machine is not pacemaker compliant. There's only one MRI on campus, which is not a breast MRI, that is pacemaker compliant. So that's her breast situation. Ovaries, she only has one ovary. Sorry, I'm trying to see the last part of my slide. She only has one ovary. However, HRT for her is contraindicated due to a shunt, because she's had high intracranial pressure and has a VP shunt in place. And so again, she's a BRCA2 carrier. Usually we don't wait till age 50 when she's menopausal to take out her ovaries, but she's worried about the HRT issue. So Liz would love your comments on that. And then the breasts, again, we can't, again, in my mind, that might kind of, when we're thinking about pros versus cons, like the benefit, it may be swayed more to potentially considering a risk-reducing mastectomy if she can't get a breast MRI. I'm not sure. And then just more of an comment on the dad. The dad was getting nothing. There were no prostate screenings. He's eligible for pancreatic cancer. So I've seen him. So all of that care has started. But again, it kind of tells you the limitations of is 23andMe testing, even in folks that are proactive, because the dad knew to share the information with his family members. He mentioned it to his docs, but still nothing was really pursued. The one other thing is I did run a can risk estimate on her, and you can see her risks are really high, right? So lifetime risk of almost 60%, but even next 5 to 10 year risks, which are more accurate, 9.2% and 20%. Ovarian cancer risks are pretty substantial as well. Lifetime risk over 20%. 5-year risk is 0.6, so I don't know, but would love your thoughts on on this patient.
Well, yes, this is a great case. So first of all, I would say I don't think hormone replacement therapy is absolutely contraindicated with a VP shunt. I obviously don't know all of her medical history, but I mean, is she premenopausal now?
Yes, she is premenopausal now.
So I mean, I would want to avoid progestin for her breast cancer risk. And so that would be a reason if she was going to have risk reducing surgery to include a hysterectomy so that you could totally avoid the progestin, and then use only a transdermal patch for estrogen, which doesn't have the same coagulation risk that oral estrogen does. And I think that that would not be higher risk than cycling, which she probably is cycling now. And that's, anyway, I don't think that's an absolute contraindication, but she is a perfect patient for the TUBA-WISP trial, which, is a salpingectomy trial where we're doing the salpingectomy in BRCA2 carriers by 45 and delaying their oophorectomy up to age 50. So that as opposed to the 40 to 45, which is the NCCN criteria. So that gets you to sort of more closer to the natural age of menopause. And the reason the trial is set up that way is because if we recommend that everybody have their oophorectomy at the age already of oophorectomy recommendation, then what are we doing by salpingectomy except giving them 2 surgeries? Like, we haven't really changed, like, ultimately the risk benefit ratio, and women obviously want to postpone their oophorectomy. So some of them are doing it on their own anyway. So we set this trial up. So if you have a BRCA1 mutation, you have to have your salpingectomy before age 40, because I think the age of the salpingectomy matters. If you waited too long to do your salpingectomy, then it may appear that the salpingectomy has failed, but you've already seeded essentially if you already passed, like, passing into your time of risk. So for BRCA1 carriers, you have to have your salpingectomy by 40, and then you can postpone your oophorectomy to 45. So that gives them 5 extra years. For BRCA2, it's 5 years beyond that. And then for the other lower risk genes, PALB2 and RAV2C, et cetera, we say, you have to have your salpingectomy by age 45, and you can do the oophorectomy whenever. So that's like an international trial that's enrolling. I think we have about 8 centers open, but you don't have to have your surgery done at the center. They can enroll and then have their surgery done and get all the information. They can enroll through one of the enrolling centers. That's a possibility. So we are trying to discourage people from doing salpingectomy off trial because it's like become the Wild West in the US a little bit. Like, we really need to learn to accumulate this information. But this is a particular patient where the salpingectomy delayed oophorectomy might be like an excellent indication. I mean, an excellent opportunity.
Yeah, no, I agree. We will distribute that information about that trial. Can you send it to
Yeah,
us? Because I don't think we're a site where it's open.
I don't think you are. It's just like, for one, it's like hardly funded. So most
No,
of the sites are kind of doing it.
but what you're saying is the patient could still have their salpingectomy here, but enroll at a site, so at least they're on trial.
I think that's true. I have to double check. I would have to double check, but I think that's
Okay.
true. I mean, that is true for the SOROC trial, which is the NCI trial that's only about BRCA1 carriers. And I would have to double check that that's true for TUBA-WISP II. I don't have it off the top of my head, but
No, but yeah, I will definitely mention it to this patient or let her know about it. Okay, I think we are out of time. Okay, so just wanted to mention our upcoming case conferences next month. We have Dr. Mark Tishkowitz presenting on his favorite topic, PALB2. And then in September, we have Dr. Doug Stewart at NCI presenting on tumor predisposition genes, penetrance, prevalence, and estimation of risks. So that's across multiple different genes, a lot of it based on the Geisinger data. So with that, a really big thank you to Liz for being our guest expert and sharing her studies and her wisdom with us. We have quite a lineup for the rest of the year. I'm going to start reaching out to folks for next year to get the schedule set. And with that, I thank you all for attending, and we will see you next time, and we will share all of the additional information on studies that Dr. Swisher has informed us about. So thank you, everyone. Bye.